think we can start off. It's time. And I'm really happy to see so many of you early morning for this topic at this time on the first day. Thank you all. So first I would like to introduce the topic, that's the corneal biomechanics. Now even though it's more of use in clinical research than clinical practice, but still most of them have been using this for clinical practice also to take decisions. More so with the glaucoma specialists nowadays. We have a team of specialists who deal with glaucoma day in and out, excluding me, who I am Dr. Somshekhar. I am more of cornea and refractive surgeon. So we'll start off with a talk by Dr. Rajesh Shashikumar, who will be talking to you about this deconstruction of corneal biomechanics, which will deal with the basic and a little bit of what exactly this corneal biomechanics is. After that, Dr. Dhanraj Rao will take care of correlation between this corneal biomechanics and tonometry. Followed by Dr. Satyadevi, who will quantify this. Then me, who will be talking on biomechanics and corneal pathologies. And we will end it with Dr. Rajesh himself again, who will tell you about the association between cornea and optic nerve biomechanics. So I think we can start off with Dr. Rajesh. I'm really sorry, the name Dr. Avijit Sinha Roy, he is not here, he couldn't make up. So his talk will be taken care by Dr. Rajesh himself. Thank you.
Morning everybody. So I would like to apologize for the fact that Dr. Avijit Sinha Roy, who is actually our biomechanics and imaging expert, was not able to make it for the meeting. So I work closely with him on a lot of these biomechanical things that we do in the hospital. So I'm going to sort of do this talk. So why are we even looking at biomechanics in the first place? So there has been, as you all know, since the time refractive surgery has started, a lot of talk on how that would finally affect, say, pressure readings, intraocular pressure readings by various instruments, and there has been a lot of advancement in the development of various tonometers that would bypass the so-called viscoelastic properties of the cornea and get you more accurate, sort of real-time sort of pressure readings of the eye. And biomechanics is also important from the time of radial keratotomy, when people started finding out that the cornea and the rest of the eye inherently became weak after doing refractive surgery. So basically, biomechanics will help us evaluate the biomechanical nature of the tissue. We'll also give us an idea about the hydration of the tissue corneal structures, and also about the stiffness of the fibers. This is also important from the point of view that people found out that central corneal thickness may not be the only parameter, or maybe not the ideal parameter to sort of evaluate, because a lot of studies have actually shown that central corneal thickness is not sort of a reliable parameter, and there are not strong correlations with, say, even intraocular pressure in some cases, and also not with the, say, progression of disease in, say, glaucoma and etc. Although it is an important parameter from an epidemiological point of view. So it also, biomechanics also will help us look at, patients who may progress in terms of disease. What is the treatment efficacy of a particular procedure, etc. And we need to sort of think about developing real-time evaluation tools for the clinician, and by doing more image processing, etc. So we all know what Gauss is. Basically, if a material is sort of stretched, there is a point in which it gets stretched, and then there is a strain, and then after that there is actually a drop off of that strain, and it's actually a comparison between stress and strain, and that actually represents the stiffness of the tissue and a higher or more stiffer tissue like steel would actually take strain better than say tissue like say rubber or a structure like rubber. Now, if you translate this into the ultrastructure of the cornea, this image on the left is a 2D constructed image of the it's actually a 2D constructed image of the retina of the cornea, and as you can see here at this point, these have been actually modified into this big picture here. So it's a 2D construction of the fiber distribution, and across the central cornea, it's more of a star-crossed sort of construction. As you go peripherally, the fiber distribution becomes more disoriented, and and depending on the depth where you actually look at this, there is a difference in how the collagen is actually oriented and distributed. In posterior stroma, it's more sort of linear, whereas in the mid stroma, it becomes randomly oriented. So, in diseased eyes, like say with the keratoconic cornea, there are blank areas in the center, and that's basically a representative of the disruption of the collagen. And if you look at soft tissue biomechanics, the response to strain and stress is non-linear, which means that, say, if you increase the stress of the cornea by increasing the intraocular pressure, the response, or rather the way the cornea responds back to that or comes back to normal is different in a normal eye and a diseased eye. And the time difference, or rather the time it takes to stretch and comes back to the normal position is actually what the hysteresis is, the area between the two curves. And so that space there is actually the hysteresis. And the machine like what we have right now in more commonly in clinical practice, like the ocular response analyzer, is actually not measuring the true hysteresis, which I will show in the further slide, but actually it measures the difference in the intraocular pressures at the time of the initial compression versus the time the cornea comes back to normal. So even with soft tissue biomechanics, the importance in conditions like myopia, the response to strain is more so in a myopic eye because the walls are thinner and the globe starts stretching. And this is what the case is in terms of a young person or young child with myopia. Adaptive mechanisms with myopic eyes what happens is that as the eye cannot focus on a structure, the globe starts stretching, and this causes weakening of the sclera and thereby lengthening of the globe as well. So the challenges here are to sort of apply all these in vivo and to sort of use this parameter to distinguish, say, normals from, say, diseased eyes. And the methods have to be based on in vivo imaging and mechanics of the collagen. So, one of the machines that we have been using for the last 2 years in our hospital is basically an air puff Corvus ST, also a tonometer, which is very similar to the ORA and gives us sort of the deformation of the cornea over when an air puff is applied to the eye. So in many ways it sort of gives you hysteresis, although it doesn't give you a hysteresis value, because the hysteresis value, as you all know now, is actually mathematically calculated. So basically what it does is there is a deformation of the apex of the cornea from the time the first pressure is applied to the point where the pressure is let go. And this deformation apex actually then gives you the amplitude of deviation or deformation of the corneal apex, and that is actually measured by the device. And various variables like the deformation amplitude and highest concavity, which means the maximum displacement of the cornea, is actually measured with this. And it also gives us, say, the corneal velocity and intraocular pressure and a pachymetry number. So the corneal velocity of the apex can actually deviate across a point in time. So this is what we marked here as appellation 1, and this would be the deformation, and then there would be the second appellation. So, and that is the appellation time. This, of course, we all know is the ORA, and unlike the ORA, the corpus actually reports how much the cornea moves in response to strain. So what are the inherent differences between the two devices? The corpus helps you actually look at the deformation of the cornea, which has some physical meaning to the, say, the biomechanical engineer, or even someone, say, that we would be able to later apply, because it actually gives some linkage to the corneal biomechanics. And the ORA only reports the intensity of the reflected infrared light and has no link to the tissue biomechanics. The corpus actually helps capture information during the entire appellation cycle. You're actually seeing variations in the deformation over the period of appellation time. And that is actually not picked up by the ORA, because it just gives you a value. It just calculates from that a mathematical model of when the deformation started and when it became normal. And that value, that's the time that I showed in the earlier slide, that is what is provided by the ORA. So it's just a number from a mathematical model with the ORA. And with the corpus, advanced mathematical models can be developed to actually evaluate the biomechanics of diseases. And this is obviously not possible with the ORA. So both devices, this is something you have to keep in mind, that report data heavily influenced by intraocular pressure and also by the corneal biomechanical properties. So where is the future of this? So as we all know, the eye is composed of very soft tissues. And we have actually looked at, there have actually been reports, which I will do in the last slide, who looked at the corneal, just not the corneal biomechanics, but optic nerve head, or the laminar preversal biomechanics. And this is the way to go, because you're looking at newer parameters to see how treatment can be changed. And so the goal would be to then describe the biomechanics with proper mathematical models and link that with biological response to the disease, and then from there on to the to treatment, and how we can actually maybe think about applying this knowledge to so modify treatment and look at other ways other than just intraocular pressure in sort of either evaluating the disease, or evaluating progression, or in regulating or preventing progression. Thank you.
Good morning, everyone. First of all, I would like to thank the AIOC as well as the conference organizers for providing me this opportunity to speak on this subject. So I'll be talking about the correlation of intraocular pressure and the corneal biomechanics. We all measure the intraocular pressure in our OPD, and we all know that the Goldman appellation tonometer is the gold standard as of now in the measurement of intraocular pressure. But is it measuring the true intraocular pressure? We all know that it's not true. The intraocular pressure measurement is affected by various factors, including the corneal thickness, the curvature of the cornea, the corneal biomechanics, tear film, previous surgery like refractive surgeries, and the other factors which are related to the examiner as well as the patient. So I'll be mainly concentrating on the corneal biomechanics, though the CCT as well as the corneal curvature is also part of the corneal biomechanics. The most widely studied factor is the central corneal thickness, its relation to the intraocular pressure. And we all know that thick corneas tend to overestimate the intraocular pressure, and the thinner corneas will tend to underestimate the intraocular pressure. And so there was a lot of correction algorithms which came up to give a corrected intraocular pressure. But now we know that none of these algorithms are accurate, and there is no correlation, there is no agreement between all these algorithms. And we no longer use the corrected IOP in our clinical management. As long as we know what a thick cornea and a thin cornea means to our patients, we don't correct the intraocular pressure. But why none of the algorithms truly work is because the relationship between the central corneal thickness and the intraocular pressure is not truly linear. They are based on theoretical assumptions, and also because they don't take the other factors which can affect the intraocular pressure into consideration. So basically, the corneal biomechanics can be understood in a very simple diagram like this. You have one chopstick here, you have multiple chopsticks. So obviously this one is going to be a little harder to bend or break. And you have a steel rod here and a wooden rod here with a similar caliber. But we know that the steel rod is much difficult to bend. So this represents the central corneal thickness, and this represents the corneal by other factors in the corneal biomechanics. Basically, the stiffer the cornea, higher the measured intraocular pressure. Softer the cornea, lower the measured intraocular pressure, regardless of the central corneal thickness. So, we are still trying to understand the role of corneal biomechanics in the disease process itself, as well as the role of corneal biomechanics in the intraocular pressure measurements in the normal and glaucomatous eyes. And in that process, we have a few instruments which try to put in the information available about the corneal biomechanics and come to some conclusion about the intraocular pressure. Some of them Dr. Rajesh has already mentioned: the dynamic contour tonometer, the ORA, and the CORVIS. Dr. Rajesh has already described what ORA is and what it measures. Basically, there are 4 different parameters: the corneal hysteresis, the corneal resistance factor, the Goldman correlated intraocular pressure, and the cornea compensated intraocular pressure are the 4 parameters which the ORA measures. We know that the corneal hysteresis is low in patients of glaucoma, both open angle and angle closure. When it comes to the intraocular pressure measurement by this instrument, both the IOPG and the IOPC, that is the IOPCC, that is the corneal compensated, as well as the Goldman correlated IOPs, they are measured little higher than the gap values. This is consistent throughout all the studies. When it comes to agreement between the GAT and the IOPG and IOPCC, they have very wide limits of agreement. That means the values cannot be interchanged. And there is a stronger correlation of central corneal thickness on the IOP with the IOPG than the GAT. I will explain to you later. Basically, the non-contact tonometer process, the suitability of such a NCT process to determine corneal biomechanics and the true IOP has not yet been demonstrated. As Dr. Rajesh has mentioned, we are still working on it. And so the corneal hysteresis and the CRF can only be partially valid for corneal biomechanics. And we know that how the ORA measures each of the parameters, P1, P2, and the constant. This is all that is used in calculating the intraocular pressure as well as the corneal biomechanics. So how close it is to the true corneal biomechanics is still not clear. Whether it is really measuring the corneal biomechanics or something else is still not very clear. So when we look at the corneal effect on the tonometry itself, this is the Goldman application tonometer, that for every 0.19 millimeters of mercury, For every 10 millimeters of central corneal thickness change, there is a 0.19 millimeters of mercury change. It is more with ORA, that is the IOPG, that is 0.33, and it is not related with the corneal compensated IOP. So in a nutshell, the IOPG has a stronger relationship to the central corneal thickness than the gap. Sorry about it. And the IOP-CC and the CCT are unrelated. That is because that is how the machine calculates it takes into consideration the CCT. That's why they are unrelated. The corneal hysteresis is not a predictive factor in deciding the GAT and the IOPG. And the CRF is the one which is associated with GAT and the IOPG. So the effect of CCT causing tonometric overestimation is encompassed by the CRF. It is related to the CRF, that is the overall corneal rigidity. So there is a lack of consistency among the ORA parameters, and the validity of these parameters are still questionable. And when you look at the intraocular pressure, diurnal variation and its relation to the corneal hysteresis. So here the CCT, the intraocular pressure and the corneal hysteresis are measured every 2 hours for a 24-hour period. Here you can see that the intraocular pressure this is the diurnal fluctuation, nocturnal spike, and along with that you can see that there is a change in the CCT also, but the corneal hysteresis remains almost flat. That means the change in the biomechanics of the eye do not contribute to the IOP fluctuation. That is another information which we can get. Coming to the Corvis, so Dr. Rajesh has already explained the deformation amplitude, the other parameters like the corneal velocity, the applanation length, and the other parameters that can be obtained along with the intraocular pressure. When we look at the repeatability and reproducibility of the ORA intraocular pressure, the Corvis intraocular pressures, they are quite good. Both the repeatability and the reproducibility. And it correlates well with the GAT values also. It gives a slightly lesser intraocular pressure reading than the GAT. But in our own study in the group of primary angle closure disease, in the PACS group, actually the Corvis showed little higher intraocular pressure readings than the GAT. Same in the PAC group, but there was a slight overlap, and it is slightly lower readings in PACG. So the corneal deformation amplitude has a good intra-class correlation, and the studies show that there is no difference in the corneal deformation amplitude between glaucoma and non-glaucoma groups. It is associated with age, intraocular pressure, and CCT. This is an example of 2 patients of a similar age group. And this patient has a normal intraocular pressure, and this patient has a very high intraocular pressure of 30. You can see that the deformation amplitude here is more as compared to the person who is having a higher IOP. So the intraocular pressure plays a role in the corneal deformation amplitude. So this is the deformation amplitude data which we have in our primary angle closure disease patients. As expected in the PACG group, the deformation amplitude is lower. So in the multivariate analysis, the only factor which is associated with the intraocular pressure difference was the corneal deformation amplitude in this study. Coming to the DCT, DCT is supposed to measure the intraocular pressure independent of the central corneal thickness, the corneal shape, and the axial length, and it gives a little higher reading as compared to the gap, and it has got excellent intra-observer and inter-observer variability. In this study, where they compared the intraocular pressure pre and post LASIK, when they checked the intraocular pressure after the LASIK procedure with the Goldman application tonometer, all the values were much lower than the pre-LASIK values. However, when checked with the DCT, you see that the pressure difference between pre and post remained almost the same. So they remain unchanged. So probably DCT is a better instrument to check the intraocular pressure in patients who have undergone refractive procedures like LASIK. When we checked the correlation between the DCT, Corvis and the ORA with the gap, we found only a moderate correlation between the Corvis and the gap, and the rest of them were poor in the normal patients. And so similarly, moderate correlation in the glaucoma patients. So none of the currently available instruments are perfect enough to measure the true intraocular pressure, and probably it is worth exploring the deformation amplitude and other waveforms which are available with the Corvis to understand the corneal biomechanics in a better way, and probably be able to measure the intraocular pressure more accurately. Thank you.
So I will be talking about the quantification of corneal biomechanics. We have been hearing a lot about corneal biomechanics and how they influence intraocular pressure measurement, but how do we quantify this? So as has been described, cornea is a complex viscoelastic structure, and the term corneal hysteresis actually reflects this viscoelastic property of the cornea. And the corneal hysteresis occurs because of the viscous damping that occurs in the cornea, and it indicates the biomechanical integrity of the corneal tissue. Earlier, corneal biomechanical evaluation was limited to in vitro studies, and by using mathematical finite element models, some idea about what may be happening within the corneal tissue was inferred. However, with the introduction of the ocular response analyzer, the ORA, in 2005, and more recently the Corvis instrument, we can actually quantify what we think is a measure of the corneal biomechanics. So the ocular response analyzer is a novel instrument which measures the intraocular pressure in the eye by a non-contact method. It was also, like I said, the first instrument that could actually measure the corneal hysteresis. The procedure is quite simple. The patient sits in front of the machine and is asked to fixate on a green light. And there is a pulse of air which hits on the apex of the cornea. Because of this pulse of air, the cornea undergoes deformation, and this deformation is then recorded, measured, and then given to us in numbers, which tells us what is the biomechanical status of the eye, as well as, like I said, other numbers for the pressure measurement of the eye. Now, if we look at the way it works, it's a bidynamic process. It's a bidirectional dynamic process which is similar to non-contact tonometer in the sense that the air pulse hits the cornea, deforms it to a point where it reaches applanation. Now, in non-contact tonometry, at this point, the process stops. However, in the ocular response analyzer, the process continues, and the air pulse continues to be delivered to the cornea beyond this process of first applanation. So with that, the cornea moves further. So this is the air jet that gives a very precisely metered collimated air pulse. And what happens to the light is there is a light emitter and there is a light detector, which using this electro-optical system, it exactly measures what's happening to the amount of light that comes from the corneal applanated surface. So this now with the air pulse has reached from the normal corneal surface, it has now come to the position of applanation. The air pulse continues And so the cornea then goes into a point of concavity. Beyond the applanation, it goes into concavity. And now the air pulse is stopped. Once the air pulse is stopped, the cornea starts returning back to its normal convexity. During the process, it comes back and passes through a process of applanation once again. So there's a second applanation event that happens. And this applanation event is again recorded, and it then finally reaches its undisturbed convex procedure. Now, because of the corneal damping or the viscous damping of the cornea, the first applanation event and the second applanation event are happening at different levels. So the P1 or the pressure 1 and P2 or the pressure are different. P2 is always lower than P1. Now this entire process of the first applanation going into concavity and then coming into the second applanation and normalcy happens within just 20 milliseconds. So the time frame is so short that the pulse, either the ocular pulse or movement of the patient does not have any kind of impact on this measurement. Now, if we look at what we see, what is the signals, the measurement signals that we get, this blue line here that we see is the actual air pressure. So it starts and then reaches a maximum, and then the air pressure is shut off and it goes off down. Now, when it has reached this point where the red signals actually indicate the raw signals of the corneal deformation process, and there is one more blue line which is underneath, which is actually the filtered signals from the cornea, which tells us about the applanation events. Now, if we drop a perpendicular from the tip of the first peak to where it intersects this air pressure curve, that gives us P1. The second dropping a perpendicular to the curve here gives us the second pressure P2. So this is indicated by these small blue squares that we see here, and we see that P1 and P2 are not at the same level. The difference between this indicates corneal hysteresis. So corneal hysteresis thus is the difference in the inward and the outward pressure values, P1 minus P2, and this measures the viscous damping effect in the corneal tissue in response to deformation. Now, if there is a greater difference between the two, it is suggestive of a stiffer cornea. So, like I said, corneal hysteresis measures the viscous damping or the energy absorption capability of the cornea. It measures the viscoelastic response. It is not very strongly correlated with intraocular pressure. Now, the ocular response analyzer also gives us another reading called the corneal resistance factor, and this is an indicator of the total corneal response. So this includes the elastic resistance of the corneal tissue, which is not taken into consideration in the corneal hysteresis. So this is the viscoelastic response that is weighted for elasticity of the cornea also. Now CRF equals P1 minus 0.7, which is a constant, P2, and this is strongly correlated with intraocular pressure measurements. The corneal resistance factor, like I said, is the overall resistance and is based on an empirically determined linear combination of P1 and P2. Now, what are the normal values? So, how is it represented? It is 10.8 millimeters of mercury. The CRF, which is quite similar to the CH, would be around 11 millimeters. From studies, we know that these are the normal values, and most studies have shown that in glaucomatous eyes, the corneal hysteresis have been found to be much lower than in normal eyes. Now, the second instrument that gives us some measurement of the corneal hysteresis is the corvus, which actually stands for corneal visualization using Scheimpflug technology. So here we are basically, again, this is a non-contact tonometer, and we are again looking at the reaction of the cornea to a symmetrically metered air pulse, again similar to what happens in the ORA. But here what we do is to actually visualize and measure this response using the ultra high speed camera. So this also measures the intraocular pressure, gives us the corneal thickness, and measures the biomechanical properties. What are the features that we get? What are the measurements that we get from the corvus? The most important is the deformation amplitude, or the amount of corneal deformation that happens with the air's puff hitting the cornea. Then there is applanation length, corneal velocity, the intraocular pressure measurement itself, the corneal thickness, and we get images of the applanation moments, and we get a video of how the cornea actually deforms. So if we look at the deformation amplitude, Dr. Rajesh has already mentioned about this. How much of the cornea, so here in this I can show it, this was the original corneal shape. With the air pulse, how much of the cornea actually went down, how much did it deform. So this gives us the deformation amplitude. So as has been mentioned, any cornea that is stiffer does not deform easily, any cornea that is thinner is going to deform more. So this measurement tells us how stiff or how weak is the cornea. It also tells us about the applanation time 1, applanation 2, and the time for highest concavity. So if you look at applanation time 1, that is 7 milliseconds. So that is the point from the start of the air pulse to the point where the first applanation actually occurred. For maximum concavity, it takes about 14 milliseconds. And that is what is given here. And the time from the start to the second applanation event is the time that is given here. Then it also measures the chord length of the applanation. So if we look at this diagram here, if we were to imagine this to be applanated, so this distance or the chord length at the time of first applanation, chord length at the time of second applanation is given. What is the corneal velocity or the speed at the first applanation, second applanation, that is given. The intraocular pressure is given, pachymetry is given. Because the cornea is deforming back and coming back to its normal position, this is given as a negative or a minus. There is a deceleration, so there is a minus that is seen here. So this is a video of what it gives. So this is how the cornea, you can actually see it going down and deforming that way. In a keratoconus eye, you can see that the cornea really deforms a lot, whereas in a normal eye, it's not much. In eyes that are stiffer, you see very little deformation. This inspection of the corneal deformation during the non-contact tonometry enables the characterization of biomechanical properties of the cornea, and it can be severely influenced by intraocular pressure. Dr. Dhanraj has just shown us how different it changes if the pressure is 30 and if the pressure is 10. So what are the normal values? From a study by Roberts et al., deflection amplitude is around 1.04 millimeters. The applanation length 1 is 1.99 and applanation length 2 is always higher, that is 2.3. Velocity inward is 0.21 and velocity out when the cornea is coming back to its normal state, that is minus 0.32 millimeters per millisecond. So increasing pachymetry correlates with increasing stiffness. Stiffer corneas have lower velocities, they don't the speed is lower, they have greater applanation lengths, flatter curvatures at the highest concavity, and a narrower displacement at depth. So corneal deformation following an air puff allows the measurement of dynamic properties, and these are essential for the characterization of corneal biomechanics. Quantifying this is useful in evaluating the influence of corneal properties on intraocular pressure measurements as well as in corneal pathology. Thank you.
Thank you, Dr. Satyadevi. I thought that was the simplest way of putting what ovary and corvus was. And as Dr. Dhanraj has put up, the difference between IOP measurement and comparing it with the gold standard, that's applanation, gap. What was the difference? Anyway, early morning, too many values to remember. I know it's not really possible for the first time, but once you keep talking about this ovary and corvus, start discussing it, that's when you will start remembering these normal values. That's how you start comparing whether it's high, low or normal. Anyway, I don't have any financial interest with this machine or any product. Actually, corneal biomechanics is a science that studies with the equilibrium and deformation of tissues. To put it in simple English, ORA has been clearly explained now, which just measures the viscous and the elastic qualities with a calibrated air pulse. Why calibrated? Because we need to measure. Simple. So overall, the capacity of the tissue to recover from its original shape after external force is applied is what this corneal biomechanics is, which has been put into two different things, which are corneal hysteresis and resistance factor. Corvus has been explained in detail. Thank you. I will not go into it. So, where it is used, basically the device uses this application of cornea with high pressures. Anyway, usefulness of this device, again, at least Dr. Dhanraj has shown, compared to other tonometers or compared to ORA to get, this correlates much better. There are other ways of measuring corneal biomechanics other than these two, but these are difficult to understand, so not frequently used also. Those are shear wave propagation imaging and OCT, which uses a special software for that. Anyway, here I will be talking of this use of corneal biomechanics in corneal pathologies. All this time you have heard about IOPs, but here I will be talking of corneal pathologies, but how the hell is it related? Once in the normal cornea you can measure with any instrument you have, but once the cornea is abnormal, that's when the problem starts with what you measure. That's why all these equipments are coming to the market. Fine. But none of them are accurate even now. So in keratoconus, as you know, it's a progressive disease, problem with the collagen network. So since essentially it's the stromal problem, and Dr. Satya has clearly shown the amplitude deviation with a normal corneal stroma and with a weaker stroma. So the changes are, we get early changes with these machines so that the disease can be picked up earlier. So these instruments can be used in the clinical practice also to detect diseases at the earliest stage itself. Most commonly in our place we use it for post-collagen cross-linking. Many studies have been done. One I have cited here. Basically, there is a significant increase in biomechanical properties after cross-linking. That's the inference of the study. Basically, this cross-linking, that's the C3R, what we call, do actually help. But again, not in 100% of the patients. But something is better than nothing. I don't think we have anything else to stop keratoconus progression, or most of them are in trial and error phase. So this biomechanics was also checked with other corneal pathologies. Most of you will know that keratoconus, post C3R are the two most major places where this corneal biomechanics have been studied in detail. There have been other studies where corneal biomechanics have been studied with other dystrophies and corneal pathologies, where it has been shown that corneal biomechanics with CH and CRF both are reduced with corneal dystrophy. Main reason not known, most probable cause is the corneal thinning that's associated with that, especially the macular dystrophy. In Fuchs, again, the normal which is supposed to be 10.3, here it's reduced to 6.9. So, why it's reduced? No answers yet. We need to find out. But compared to normal eyes, the Fuchs dystrophy patients do have reduced corneal hysteresis and resistance factor. after keratoplasty. Yeah, that's really a nice topic to talk about. But since we are using a totally different normal tissue, what should be the reaction, nobody knows, because we also have corneal scarring along with it, and there is peripheral rim of the original tissue left. So while the studies have found that CH and CRF approach almost near normal range after penetrating keratoplasty. So how about post DSAK? Again, with keratoplasty, full thickness keratoplasty, it has shown near normal values, but with these procedures, it's again showing less values. So, basically corneal biomechanics decreases with DSAEK. And comparing DALK and penetrating keratoplasties, the CH and CRF were significantly lower in penetrating group compared to DALK group. Again, all these studies have limited patient numbers and only 1 or 2 studies. We need a larger randomized clinical trial to give you an opinion whether what exactly it is. Post-LASIK, of course, everybody knows it decreases because we are burning out some of the tissues. Thank you. There is one more talk by Dr. Rajesh. After that, we will conclude the session and we will take questions of the whole session. Thank you.
So I think we sort of dwelt on the anterior part of the eye for a while. So let's see whether we can actually look at how we can link this to say why disease progression happens. Are there any other sort of comparable parameters at the back of the eye that we can look at that can help us look at how biomechanics can influence the response of the eye to stress and strain? So we all know that higher IOP is associated with increased prevalence of, say, glaucoma, and while lowering the intraocular pressure reduces the progression of the disease. The level and stress and strain of the disease, that is the shear, compression, etc., depend on the mechanical behavior of the, say, the cornea, maybe the lamina preporosa and the surrounding sclera. As we all know from our days with using the shields, there was this component of ocular rigidity that would affect the, the readings. So there is definite role of IOP in this. And the biomechanical perspective is that the intraocular pressure is a mechanical load on the eye that generates stress and strain, say at the level of the optic nerve head. And the optic nerve head is obviously the site of interest because it represents the weakest spot in the corneoscleral shell, if you may call it that. So the biomechanical theory of glaucoma is that what is interesting is that sometimes when the pressure is high, some eyes do not progress or there is no obvious nerve damage, whereas some patients progress or develop disease despite having normal intraocular pressures, as we know that we call the low tension or the normal tension glaucoma patients. So there is some sort of responses happening that generates disease. Now, we also know that there is an increased predisposition to glaucoma with aging. And that could be related to age-related changes to the biomechanical behavior of the ocular tissue. So how does this help? How does this information help us? Maybe at some point in time we're looking at manipulation of these biomechanical properties to develop a potential therapeutic target to try and prevent progression other than just monitoring and treating intraocular pressure. As we all know that the intraocular pressure reduction alone does not sometimes prevent progression of the disease in a large percentage of people. And since we also don't know what the so-called target pressures are, these are all at this point in time best empirical values more than anything else. So if you look at the laminar tuberosum as a sieve, which allows these little pores that allow passing of the optic nerve head or the optic nerve axons and the blood vessels, and you look at the response of the optic nerve head in this is the monkey model on the left side, which actually looked at the response or the response to strain to intraocular pressure. You see that in an experimental monkey model, the response of the glaucomatous optic nerve head or lamina tuberosa was more in terms of, say, let's call it more elastic, more rebound than, say, in a patient or in an eye which is supposed to be normal. So there are lots of papers that have been published in terms of corneal biomechanics. We know that corneal hysteresis is lower in ice glaucoma that we've already spoken about in the previous article presentations. It's also been shown that corneal hysteresis is lesser in eyes which have larger cup-test ratio or deeper cups. We also know that lower corneal hysteresis is a risk factor for progression, and we also know that lower corneal hysteresis is associated with more severe disease. So IOP-generated stress is basically a pressure differential that happens, and this transmission of the intraocular pressure-related stress leads to permanent deformation, if you may, at some point in time, over repeated insults, as you would call it, to the optic nerve head. And that's what we normally tell patients, that over a period of time, repeated insults of intraocular pressure will eventually cause death and non-regenerative stage of the axons. So there is obviously an established role of the ocular tissue, connective tissue, if you may. There is also it's also been shown that hysteresis is a definite risk factor, and connective tissue adjacent to the RGC axons in the optic nerve head, basically the beams of the lamina tuberosa, are just as much involved, as has been shown in multiple animal models, as are the corneal biomechanical so-called properties. Now, if you look at this image, you can actually, I hope this works. This area has been marked out as an area of damage, and here the pores seem to be more oval and less in number, say this area, which seems to have more number of pores and wider pores. So, interestingly, where this is taking us is that the cornea and the optic nerve head lamina tuberosa appear to have uniform collagen fiber diameters compared to, say, areas around the optic nerve head, where the posterior sclera in that area have a crisscross or arrangement of the optic nerve head or of the collagen fibrils. So if you look at this image, you're actually looking at intraocular pressure and the prelaminar pressure actually influencing lamina tuberosa. And once the lamina tuberosa, what we can right now image normally is at the level of the lamina tuberosa anterior surface, and newer developments will hopefully at some point in time let us look at imaging things below that. Now, there have been some people looking at how the intraocular pressure induced deformation of the lamina tuberosa plates and the scleral canal will actually affect the biomechanical properties of the eye. And interestingly, they have found that it is not that the eye is stiff and the cornea are stiff and the lamina is stiff and so on and so forth. There can be variations. So you can have a stiff sclera and a more compliant lamina, or a compliant sclera and a compliant lamina, and so on and so forth. So one of the interesting things that many of the engineers have actually found out is that intraocular pressure in general causes stiffening of the tissue. And that's what Raj showed as well, that when the pressures are 30, there is actually less deformation of the cornea. And this is also true of the optic nerve head. They have shown that the lamina tuberosa and the optic nerve head gets more stiffer and less malleable, say, than with lower pressures. So whether this stiffening is actually protective or damaging is something nobody knows yet. So as of now, till today, we have the earlier methods to actually look at the lamina tuberosa or has been various, say, bench-side methods of doing it, like static histomorphometry, indirect measurements, say, histopathological evaluation, 3D deformation analysis, finite modeling. They've also used second harmonic thing and models to actually create, and lots of them have been primarily lab-based. Clinicians have now, for the last year, at ARVO in 2013, there were more than 20 or 30 posters looking at the lamina cribrosa, and there's been a lot of interest recently where you actually look at using technologies like the OCT, adapted with modified or enhanced imaging like the adaptive optics, or even EDI, which is the enhanced depth imaging scan protocol of the spectralis OCT, where we're actually looking at imaging the lamina cribrosa and making it more sort of, say, achievable for the clinician to look at that part of the eye as well. So if you look at this image, you're actually trying to see the optic nerve head, and this is the area with the lamina cribrosa, anterior surface of the, or what we call as the anterior lamina cribrosa surface. And in the next image, you'll actually see where the arrow marks are. Those are areas which are focal defects, which are actually representative or correlating with the optic nerve head changes that you can actually see. So at our hospital, we use a device called the RTX1 adaptive optics device, which is a standalone camera. It is not attached to an OCT, and this is actually an in vivo, as you would say, live imaging of the optic nerve head canal or the lamina cribrosa. So this is a 4x4 image which we get for infrared wavelength. The machine acquires about 40 images for every 4 seconds, and then it does the registration and averaging. So basically, the reference plane is at the level of the anterior lamina cribrosa plate, and then we've actually then looked at the pore count, the shape of the pores, the pore area, the spacing between the pores, etc. And what we then did was we used a freely available software called ImageJ, which is a validated software available from the NIH website, and actually deconstructed the image and looked at the pore area and counted all the pores, and then did some basic analysis. So we took about 20 patients in about both groups and looked at in groups with glaucoma and non-glaucoma, and looked at some interesting findings. So as we all know, we have spoken about the corpus ST in the previous talks ad nauseum, so I won't go there. So maybe because the numbers were small, we did not find any significant difference in the area under the deformation amplitude curve. Now, what the machine actually gives us is the deformation amplitude curve, but what our team with, as I mentioned, the first talk I did on behalf of Dr. Abhijit Sinha Roy, what they actually do in their biomedical lab is that actually they calculate the area using mathematical models under the deformation amplitude, which is actually a true representation of how much the cornea actually moves in response to stress, say intraocular pressure here. And there was no difference between the glaucoma and the non-glaucomatous group. Neither was any difference, say, in the mean pore area or the pore count. The caveat here is that the intraocular pressure was treated or, say, modified. And as I mentioned in the earlier part of the talk, that having patients with, say, uncontrolled pressure or raised pressure might have actually changed the way these results would have looked, because when the pressure is high, the cornea is stiffer, the optic nerve head lamina cribrosa might be stiffer, the pores might be, tighter, and we would have had different results falling out. So we did a scatter plot and actually looked at correlating the area and the deformation with the mean pore area. Looks like a great regression line, but there are too many outliers there because the number of samples were less. And this was similarly, we also looked at the area and the deformation amplitude, and also compared that with correlating with the optic disc area. That optic disc area was calculated using the spectral domain OCT spectralis machine, and again, good looking curve but not meaningful. So what are the implications here? What can we take from this? Now we all know the optic nerve head tolerance for a given intraocular related stress is dependent on the magnitude of the intraocular pressure and also on the capacity of the RGCs to respond to the stress. So mechanical loss in general would then define glaucomatous optic neuropathy or cupping. Now, what is the predominant mechanism? You will find optic nerve heads that are pale, you will find optic nerve heads that are cupped. Now, what is more important here? Is it mechanical or is it vascular? Nobody knows. Having said that, Claude Burgoyne's group have done extensive work on this from the University of Pittsburgh. They actually looked at the fact that they've actually came to these conclusions that excavation, if there is excavation, irrespective of what the intraocular pressure is that you see, you should treat. You should look at treating these. And even if there is more pallor, there could be a vascular component. Having said that, you should still think about treating aggressively because maybe, just maybe, intraocular pressure lowering might actually control the progression. Now, another implication is that we also know that intraocular pressure lowering protects the connective tissue and maybe increases the perfusion. There have been other studies that have shown this. If there is still progression, most probably there are extraneous factors like nocturnal hypotension or immune-mediated mechanisms that are causing the further damage to the tissue. So, what are the future directions? So, what do you think we can take home from this? One of my colleagues who have actually worked, Dr. Abhijit Roy, has actually written this paper with Dr. Thornton, and they've actually looked at, they've actually done a few animal models with porcine models as well as in a few cadaveric eyes where they actually cross-linked the posterior sclera. I mean, everyone's cross-linking the cornea all over the place for keratoconus, and that's showing fantastically positive results right now in terms of delaying or arresting progression of the disease. So maybe collagen cross-linking of the posterior sclera to protect the optic nerve and the lamina tuberosa from stiffening or, say, causing stiffening during intraocular pressure elevation might be a possible way. And how do we do this? We have to make sure that we actually know what happens to the lamina tuberosa pre-treatment, that is before treatment. We haven't done that. That's something we're going to do in the future. And based on available data, especially with the devices that we have, then we can look at back calculating the tissue biomechanics and predicting which eyes may actually progress, which eyes may not, with or without treatment. Thank you.
Free to take now. No questions?